Hey everybody, I'm Marc. Let's just get started. So today I'm going to be talking about pre-hospital stroke management. So I'll talk a little bit about what that means and why we think it's important. And this is meant to kind of be like a general overview a little bit. So why do we care about the pre-hospital treatment of stroke? So we know it's a kind of wide-held mantra that when it comes to stroke, time is brain. But let's kind of zero in a little bit more on what that means. So one kind of prevailing theory in like the pathophysiology of stroke is you have what's called the infarct core and the infarct penumbra. What's thought is when someone is in the early portion of their stroke, they have a small infarct core with irreversible damage. And there's this penumbra, which if we can treat it quickly enough, we can help reverse this tissue ischemia and lead to better functional outcomes. We really have two main ways in which we treat that. So the one that we all really love is when someone comes in with a nice juicy LVO, we do thrombectomy, right? We get someone to an LVO capable site. And in general, patients who are amenable to thrombectomy do better than those who receive thrombolytics. And then there's TPA. We don't love TPA, and we know that TPA carries a significant risk of intracranial hemorrhage. But if we go to the data for a second and use our trusty NNT, we know that, first of all, to describe the harms, the number needed to harm when giving TPA, pretty much universally across 0 to 6 hours, is a number needed to harm of about between 40 and 50. And then the all-cause 90-day mortality is a number needed to harm of 71. This is not negligible. However, if we go to the number needed to treat, we can see that clearly there's a greater benefit in excellent functional outcome when administering TPA as early as possible from the onset of the stroke. And in the appropriate patient who is amenable to TPA and has presented within a reasonable time frame, time genuinely does equal tissue. So in that sense, you might argue that the best time to give TPA, if you're able to do it, is during the pre-hospital setting. That's when you first essentially identified the symptoms of stroke. And this goes along with the idea of preserving the ischemic penumbra and saving viable brain tissue. So we want to give TPA faster, obviously. This, just a quick side note, this is ultimately relevant to our practice, and I'll touch on this a little bit at the end also, because if someone truly comes in within 3 hours of stroke onset, you really do need to have a good, honest discussion with TPA. And you really have to mobilize your neurology colleagues as well, because if someone presents within 3 hours, you really want to have that discussion about TPA in a more serious manner that not only discusses the harms, but genuinely brings up the benefits. So let's bring it to pre-hospital care. So briefly, what we're going to talk about, this is just a little image that kind of discusses the natural progression of how we identify and treat strokes. So you have a bystander who recognizes something. They may even recognize that this patient has a stroke. Then they activate EMS. EMS agrees. They activate some kind of notification, and then they bring the patient to the hospital. And when they're in the ambulance, they do some kind of triage or treatment to decide where that patient is ultimately going to go. So first, let's briefly talk about just bystander recognition of stroke. So this is a nice little kind of mnemonic that actually is taken from the stroke scale. The actual scale that's used is face, arm, speech, and treatment. But if you bring this to the community, you can say face, arm, speech, time. So someone who has any kind of facial droop, any kind of arm weakness, any kind of speech difficulty. And then if you notice any of these things, just call 911. There are a number of single center studies that have reported increases in TPA treatment after public awareness campaigns to the identification of stroke. But it's hard to attribute these increases to actually greater awareness, as all these studies kind of coincided with things like stroke protocols and the general regionalization of stroke care. Just a quick comment on that. So next, let's talk a little bit about identifying stroke in the EMS setting. So just very quickly, there are a lot of different stroke scales, and there was a recent observational study called the Presto trial, which basically looked at all these scales and compared them. And just to quickly comment on it, most of these scales have a certain degree of sensitivity at the expense of specificity, and all of them really approach about an 80% sensitivity for detecting LVO, and the NIHSS is the best one. As you probably know, none of these stroke scales are really designed for identifying more subtle strokes, in particular posterior CVAs. So this is really to identify your LVOs. But regardless, use a stroke scale that you feel comfortable with, that you can use in a standardized fashion, so that you can screen for your CVAs, whether you're in the pre-hospital setting or whether you're in the ED. So once you've kind of identified that you think a stroke is going on, you need to notify the receiving hospital. Now, as we're all very, very acutely aware of, EMS equipment is related on very outdated radio technology, and there's lots of flaws when it comes to communication. I mean, going away from stroke for a second, we've all received, the faxed EKG an hour after the patient presents to the hospital. We've all had situations where we didn't get the packet, we don't know what happened in the previous institution or during the pre-hospital setting, or the ACR isn't uploaded. So there's lots of deficiencies, and when you have a condition that's time sensitive as stroke, that's something you really want to have all your information as quickly as possible. So one of the things that's actually it's prominent in hospital literature, but also now in pre-hospital literature, is that telemedicine, and telestroke in particular, has become a very popular way, having face-to-face conversation or immediate access to a vascular neurologist en route is something that is very beneficial. And perhaps more practical for us is there's lots of apps that centralize all your information sharing. So there's one app in particular that actually has studies behind it, which is called the Join app, which is a smartphone kind of app system where, as long as the hospitals are participating, you're able to communicate all sorts of information: vitals, CT imaging, EKGs, basically anything you can think of, and anyone who has this app has access to that information in real time. So in so doing, you standardize your communication and the data that's being looked at between hospitals. So you go from something like this, the dreaded CD, which about 99% of the time never works, and you end up getting another CAT scan anyway, to this, a genuine kind of integrated network where everyone's on the same page in real time, aware of what's going on with the patient, and you avoid redundancy, and in so doing save time. So that's kind of a quick kind of overview of the first two things, and now I'm going to spend the most of the rest of the talk talking about what happens in the ambulance, how we get the patient to the hospital, and a couple of studies related to that as well. So first, let's go to transport for a moment. So there are three kind of main methods that I'm going to talk about. The first is the drip and ship method, the transport method, the mothership, and then finally we're going to touch extensively on mobile stroke units, because that's really kind of the hot topic in pre-hospital literature nowadays. So drip and ship, I'm going to say right now, is the most important thing and most relevant to us, because we employ a drip and ship model. As a primary stroke center, we have the capability to administer TPA, but we're not a comprehensive stroke center, in that we do not offer thrombectomy for LVOs. So in these cases, what happens is EMS identifies a stroke, and they bring the patient to the nearest capable prime stroke center, be it a primary stroke center, sometimes a comprehensive stroke center, but that's another model that we're going to discuss. So once we've triaged the patient and spoken with the patient, we make the decision over, are we going to give TPA or not? Does this patient have an LVO or not? And then we ship the patient over, if we think it's indicated, to a comprehensive stroke center where they're thrombectomy capable. So this is the model of Kings County, so it's just important to be aware of it. And then there's the mothership, which intuitively feels like the best thing for the patient, but we're going to talk a little bit about why that may not be the case. But that basically just involves EMS identifying symptoms consistent with something like a stroke, and they bring them straight to the mothership, straight to the comprehensive stroke center that's TPA and thrombectomy capable, and you bypass the local center or the primary stroke center. Now, it would be tempting to bring a patient straight to the mothership, but as I've been kind of alluding to, stroke is a very time-sensitive diagnosis. If you decide to transfer a patient to a comprehensive stroke center, that's particularly one that's further away, at the expense of missing that TPA window that we discussed earlier, two things happen. One, you've missed the opportunity to really explore the full benefit of actually giving someone TPA. And then what's more is that just because you bring someone to a thrombectomy center doesn't mean they're going to get a thrombectomy. So not only that, if that patient ultimately doesn't get a thrombectomy, you've really exhausted both of our only emergent treatment options that we have for the treatment of stroke, and they have to rely on post-stroke care, which is very important and very robust. But if we can do something, we should be able to do it. So on the one hand, we want to, within reason, administer TPA as early as possible and rapidly deliver to the patient to give them the best chance of a good or excellent functional neurologic outcome. On the other hand, we want to rapidly identify thrombectomy eligible patients and get them to a comprehensive stroke center ASAP so that they can actually get thrombectomy. So enter the concept of mobile stroke units. It's very tempting, right? You have ambulances that are fully stocked. They have a CT scanner, point of care laboratory testing, personnel trained to diagnose and treat patients with stroke, and they're able to rapidly triage patients for TPA. One might argue that this is the ultimate in stroke care coordination. You do an early CT, at least to rule out a bleed. You identify a TPA candidate. You, in coordination with a teleneurologist, you might administer the TPA. Meanwhile, if you think this patient has a high probability of having an LVO, you either get them to the comprehensive stroke center because you can cut out the middle person of the primary stroke center because you've already decided that this patient either does or does not need TPA. So that all sounds pretty good, right? The unfortunate thing about it is there have been mobile stroke unit studies have shown reliability in diagnosis of stroke and reductions in time to treatment, which we'll talk about a little bit later. But what they have not, these are really surrogate endpoints, and they haven't shown any good patient-centered outcomes, particularly as far as things like functional neurologic outcome or recovery. So enter the hottest study on the block right now, which we'll talk about. It's Pitfalls, which is the best MSU study, which was a prospective, multi-center, alternating week, cluster-controlled trial, which was meant to improve, which was looked at clinical outcomes in patients who were eligible for TPA in a mobile stroke unit as compared to those with EMS. Each mobile stroke unit was staffed by paramedics, CT technologist, a critical care nurse, and then vascular neurology was available by telemedicine. So the inclusions it's kind of basic inclusion and exclusion criteria. So they included patients with examinations consistent with acute CVA, those who had an onset within 4.5 hours, those who had no obvious guideline contraindications to TPA, and they excluded things like stroke mimics, which we'll talk a little bit about, people who are out of the time frame for TPA, and those who were otherwise ineligible for TPA. So on the weeks when the mobile stroke unit was assigned, the mobile stroke unit and the EMS team was dispatched. They did things like a point of care glucose. They did a general exam. They established an NIHSS scale. They did a non-con of the head. And if there was no concern for a bleed or some other pathology, they employed blood pressure control. And if all of those criteria were met, they started the TPA bolus followed by the infusion. And like I said, if they detected something like a brain bleed, they were excluded from the study. Of note, there were 3 sites that were CTA capable, but not all of the sites were CTA capable. And that wasn't really a parameter that was heavily controlled or studied. And then a little bit more simply, on the weeks when the regular EMS crew was assigned, the mobile stroke unit nurse still went there to establish a stroke scale, but basically they just went through usual care. They were brought by whatever institutional protocol or ambulance protocols to the nearest stroke center where they were otherwise evaluated by the ED team and the stroke team there. The primary outcome, just want to spend a small amount of time talking about it. So classically, what's used is the modified Rankin scale, which goes on a score from 0 to 6, 0 indicating no disability. Oh, sorry, I apologize. 0 indicating no disability, and 6 indicating something like death. They wanted to use a utility weighted modified Rankin scale because in other studies, basically they want to account for smaller differences in functional neurologic outcome. With the modified Rankin scale, you have really essentially the scores of 1 to 5, which are a little bit restrictive in their in detecting kind of clinically significant differences. At least that's what they said in the study. Secondary outcomes was the actual modified Rankin scale, which I think is a little bit more intuitive for us in the patients in the study. A 30% improvement from baseline to 24 hours in their NIHSS score, which I think is much less of a patient-centered outcome, but it was something that they looked at nonetheless, but I'm not going to focus as much on. And then many different things related to the percentage of patients who ultimately receive TPA and thrombectomy, as well as time metrics related to times to TPA and times to thrombectomy in the study populations. So yeah, so I'm mainly going to talk about those things. So ultimately, as far as the results are concerned, there was a significant difference in improvement of functional neurologic outcome from the mobile stroke unit when compared to the EMS unit. They had a mean utility weighted modified ranking scale of 0.726. So in the mean utility, higher is actually better as compared to 0.657 in the EMS group. Now, in a kind of a tangible way, I kind of bring it back to the modified Rankin scale. So what it showed is that basically on average, about 10% more of the patients had an excellent or complete functional neurologic recovery at 90 days when compared to standard management. So, and I'm going to talk a little bit about that. But first, let's talk about some of the metrics with TPA. So not surprisingly, if you bring TPA to the stroke unit, to the ambulance, you're going to reduce your time to TPA. And that, the reduction of time to TPA in combination with the improved functional neurologic outcome that was reported in the study, that kind of makes a little bit of sense and is kind of a reassuring thing, at least on the surface. Hold on. There we go. Okay. Oh, what happened here? Oh, there we go. Okay. And then also, so symptomatic intracranial hemorrhage also occurred in approximately 2% of the patients who received TPA. And that was kind of in line with other mobile stroke unit studies. Mortality at 90 days was about 9% in the mobile stroke unit as compared to 12% in the EMS group. Perhaps of no surprise, patients were more likely to receive TPA in the mobile stroke unit than with the EMS group, because in the EMS group, they were brought to the hospital where they were evaluated there for TPA. And perhaps another thing to kind of be aware of the patients who were ultimately not eligible for TPA, they say in the study, 16.7% of those in the stroke unit and 11.6% of those in the EMS group got TPA anyway. So now let's talk a little bit more about thrombectomy. So the metrics with thrombectomy, not surprisingly, I don't know why that didn't come up. Oh, there it goes. Oh, okay. Surprisingly, mobile stroke units really didn't increase the time to thrombectomy. In fact, they were about 3 minutes longer in time to thrombectomy when compared to EMS. So it looks like, at least by this study, mobile stroke units don't appear to expedite time to thrombectomy. What I would say is that perhaps if mobile stroke units became more universally CTA capable, that might change. Because as I said before, only a few of the ambulances actually had the capability of doing CTA in the study. So the author conclusion, and then we'll get to some caveats, was that in this trial, mobile stroke unit management of acute ischemic stroke in patients who were eligible to receive TPA resulted in less disability at 90 days and faster and more frequent TPA treatment than standard management by EMS. On the surface, this is kind of a reasonable conclusion, but let's talk a little bit about the caveats. And there definitely are some weaknesses to this study. There were many, but I'm going to talk about the ones that I thought were the most important to me. So for me, perhaps the most glaring is that in these studies, including this most recent study, they're not very upfront about whether the patients who ultimately received TPA in the trial actually had radiographically confirmed strokes via gold standard, which is MRI. And also quite a bit of patients were excluded from the trial due to mimics, which I'll also kind of talk about. But ultimately, they don't explicitly comment on the final diagnosis of the patients who were included in the study. I lied a little bit because they do kind of mention it. You have to find it in the appendix. And it's a little confusing to me. Basically, if you look at the appendix of the people who were treated, particularly in the mobile stroke unit, you see that about 68% of them had a definite stroke, 31% a probable stroke, 16.9% stroke reversed by TPA, which is, I'm not sure about what that means. And then people who TIA, stroke mimics, and missing also got TPA. So if you look at the ones who only had a definite stroke, about 70% of those patients, about 30% of people didn't have a definite stroke and they got TPA, which again, as we know, is not a benign medication. Also of note, this is just kind of the flow sheet of the study, but I want to bring your attention to how many patients were ultimately excluded from the study. Particularly, there were almost 2,600 patients who were excluded because they had stroke mimics. And the reason why I bring this up in discussion with Dr. Reisman, in his experience with mobile stroke units, regardless of whether the patient actually gets TPA, it's a very laborious, time-intensive thing. So if you're identifying someone with a stroke mimic, and more concern, and more worrisome, someone who has a stroke mimic that is a time-sensitive diagnosis, you're delaying their care, and that can be a life-threatening thing. And as we know, stroke mimics are common. There's been a few during residency where I've seen stroke codes present as aortic dissections, STEMIs. So it's not benign. Ultimately there were only I would say about 1,200 people, I believe. Maybe I may be messing up. Ultimately included in the study from a pool of over 10,000 patients. So if you're risk stratifying, if you may be giving TPA and giving excellent stroke care at the expense of having patients who are missing time-sensitive other medical diagnoses, which may cause that patient to die. So what are the future directions? So I think we need more multi-center trials, because the other thing I should mention is, even though they recruited multiple centers, this was a study that was predominantly done in Houston. So that also impacts the generalizability of some of the data. So we need more multi-center trials looking at mobile stroke units and functional outcome. And we need mobile stroke units studies that look directly at LVOs and functional outcome, perhaps with CTA-capable ambulances. We also need studies that address the benefit risk analysis of mobile stroke units, as I was just talking about. How many dissections are we missing? How many patients ultimately have a final diagnosis of stroke? And then just a little side thing, I think this is kind of cool. This is clearly very expensive. So we need to find a way to make this a little bit cheaper. One thing which is definitely not ready for prime time yet is things like, these portable transcranial Doppler devices to detect LVOs. That's just a picture from one of the developer websites. So I thought that was kind of cool. So those are some future directions where we can maybe, clarify things a little bit more. So ultimately, what do I want you to take home from this talk? So understand kind of the paradigm of stroke care. We want to reverse that penumbra. Time genuinely is brain, and in particular, when it comes to administration of TPA, because once you've missed that window, you're really introducing more harm in giving TPA than benefit. Also, destination is key. We want our patients who are eligible for thrombectomy to get to a thrombectomy capable site ASAP. But as I said, it's not to the exclusion of TPA. There's still avenues of TPA administration that need more study. And perhaps the earlier pre-hospital administration of TPA would lead to better functional outcomes, particularly if given within 3 hours of symptom onset. And then ultimately, I think as a primary stroke center, this is our critical intervention. When indicated, ensuring the rapid delivery of TPA in patients who are under the 3-hour window, and for those for whom EVT is not certain. But then also, of course, having an honest discussion with your patient about the risks, particularly if you're beyond that 3-hour mark. Mobile stroke units are controversial, but they're interesting. They may shed light on the role, like I said, that early TPA administration plays in preserving ischemic penumbra, but they have not been shown to expedite or increase the frequency of time to endovascular thrombectomy or the frequency of treatment with endovascular thrombectomy. And then ultimately, my last thing is that it takes a village. As a primary stroke center, like I said, we take the initiative to innovate ways to quickly communicate all information to our comprehensive stroke centers, and for our LVOs in particular. We advocate for our patient when TPA is indicated and the evidence supports its administration. And we empower our patients to choose or refuse TPA in settings where the risks outweigh the benefit or the benefit is unclear. That's it. Any questions?
Thank you, Mark.
Yep.
Hi, this is Shari Zatopchi. Thank you. This was an excellent presentation. Thank you for including the NNTs, but unfortunately, you used the old, outdated NNT. The new NNT, we actually, because of the uncertainty in the data and the biases, we have assigned a yellow recommendation, which means we are not calculating the NNT, we are not calculating the number needed to treat the harm, and we are requesting new analysis or new studies for TPA. There is definitely, as you mentioned, some subgroup of stroke patients that might benefit from TPA. but we at least at NNTR.com and a lot of emergency physicians believe that we have not identified those. And this EMS, the mobile units is kind of going ahead of the game while we still haven't found the right answer to TPA, and we are trying to give TPA to everyone. But regardless, this was an interesting study. The other thing that you mentioned, and I want to emphasize, and we've seen a lot of M&Ms that we had that this stroke code has, without patient being properly examined and assessed, has caused some anchoring and some harm to the patients who actually didn't have a stroke, or they had other things going on. It makes me cringe to think that you know, no disrespect for EMS personnel, but this is, if you are to give a potentially lethal drug, the patient has to be properly assessed. The stroke has to be properly diagnosed before you give them these medications. And by focusing, unfortunately, the TPA literature is you focus on stroke and nothing else matters. And as you mentioned, there are a lot of other things that can mimic a stroke and they need attention. By focusing on a stroke, we can harm a lot of people. Thank you.
Thank you. Any other questions? Yeah.